Hey, welcome. My name is Debbie Prue. I'm the Executive Director of NAMI Pasco. This is Mental Health Awareness Month. This is session 5 of our presentations, and today we will be hearing from Christine Pringle on partial hospitalization. And with that, I turn it over to her.
All right, well, good afternoon, everyone. Thank you so much for joining today. My name is Christine Pringle. I'm a licensed mental health counselor. I'm also a master's certified addictions professional. And I thought something that might be really helpful to talk about today was partial hospitalization. Partial hospitalization is a level of care that can be a very successful step down from an inpatient level of care, or it can also be a very successful step up for someone who's in the community who potentially needs some support and essentially alleviating the need to be at that highest level of care, that inpatient. So really, partial hospitalization is a program, a modality that is bridging successful transitions. So every person on this earth is full of great possibilities that can be realized through imagination, effort, and perseverance. So just a little bit of positivity for everyone today on this Tuesday. So partial hospitalization means a non-residential, diversionary, medically directed treatment program that offers intensive, coordinated, and structured services for adults within a stable therapeutic milieu. And it is time limited, ambulatory, and an active program. So this isn't a long-term source of care. So between IOP, which is a less intensive form of partial hospitalization, it can be anywhere from about 3 to 8 weeks. And it's really there to provide that intensive support. So it's providing the intensive treatment. So to be able to be voluntarily diverted from inpatient, or also that may just need some extra support after discharge from an inpatient stay. This is to assist individuals who are really experiencing significant impairments resulting from psychiatric, emotional, and behavioral health. And it's intended to have a positive impact on the individual support system. So there's really a focus on connecting the individual to whether it be family support, friends support, community support. And it is really a highly successful component, but very, it's almost like, something that is not well known as a treatment modality, but it just has that significant link within the continuum of mental health services. I think it's like mental health's best kept secret. So I'm really excited to be able to share it with you guys. So where does PHP fall on this continuum of care? So it's right in between inpatient and outpatient. You also see residential in there as well. So residential would also be on the continuum, but that would be just a little bit higher level of care than partial hospitalization. And again, and I'll probably say this several times throughout the presentation because it's really important to know that this is care that's provided in lieu of inpatient. So, inpatient stays can be traumatic. They can actually accelerate and enhance certain diagnoses. And so as a care community, we want to avoid inpatient care if that level of acuity is not needed. So the goals are to reduce the number of days of inpatient stay, and it's best utilized when preventing a step up to a hospitalization or to support a patient's transition from inpatient back to the community. So an inpatient stay really doesn't last too long, and certain medications or modalities take several weeks to really kind of sink in and start benefiting an individual. So this is a great program and modality in order to support during that stabilization period. So this is just, I'm a history geek, so I like history. And so this is just kind of a little overview. In 1963, the Community Mental Health Act of 1963 made PHP a requirement as a core service provided by community mental health centers. It looked extremely different than it does today, but it was there. In 1987, Medicare was statutorily authorized to pay for the services. Then in 1990, there was just a little more oversight over programming. So this level of care required a physician certification, stating that the individual required this level of care. A written treatment plan was required, and also the program was required to produce medical necessity on behalf of the patient. So from 1995 to 1997, PHPs grew from 296 facility to 769. So it was a very, very useful way for individuals, again, to avoid that higher level of care, and in an effort to prevent that cyclical care where individuals would step down to outpatient, potentially not do so well on medications, decompensate, and go back to inpatient. So in 1998, there was a general audit that found some treatment fraud and highly questionable claims. So a lot of facilities that acted more so as day programs, which are fabulous. I think day programs are just absolutely great for socialization, for support, for just continued growth. But unfortunately, that is not the level of care that PHP was at. So some facilities were acting as day programs, but billing as PHPs. So then we see in the early 2000s, we do see a restructuring. And that's when we really see partial hospitalization as we do today. So some of the differences are partial hospitalization is really a preventative measure, whereas inpatient is reactionary. So inpatient there is to stabilize, to ensure the safety of an individual, whereas partial hospitalization is providing the tools and techniques for long-term stabilization. There's more flexibility with partial hospitalization. Inpatient is obviously, it's an intensive level of care, higher cost. Partial hospitalization is able to provide long-term development of skills, whereas inpatient care, that the responsibility of inpatient is really to provide that short-term safety planning. So can an individual be stepped back down and still remain safe? Partial hospitalization does a great job of providing real life situations, giving individuals an opportunity to really practice skills that they can utilize in the community. Inpatient care is a very medically based environment, and that again is for safety, whereas partial hospitalization is able to really provide some wraparound services, a more supportive environment for individuals. A lot of information here if anyone wants the information, but it really just shows some of the clinical guidelines of what an individual would require to meet medical necessity for admission. What are some of the exclusionary, and then what does it look like? How do we know that an individual is ready for discharge from a partial hospitalization? So some of the admission criteria is having the ability to maintain an adequate level of functioning outside of the treatment program. So can an individual provide from themselves, provide self security and safety without 24-hour care. There are tons of partial hospitalizations that include on-site residency as well. That doesn't mean it's a residential program. It just means that after programming, that facility, that program also has on-site apartments or homes that individuals can stay in if they need residency as well. So some of the other admission criteria is that we need to know that the individual can be reasonably expected to benefit from the treatment. So unfortunately, and we'll look at this a little bit later, individuals that have dementia or have traumatic brain injury may not be able to participate in programming. They may not have the ability to process effectively, and that would really not allow them to gain as much as another individual would. So some of the exclusionary is obviously if the person is an active and potential danger to themselves, if they have that high level of acuity, we would recommend an inpatient level. If the individual requires a level of structure supervision beyond partial hospitalization, and if the admission is being used as an alternative to incarceration. So our partial hospitalization is really there for treatment and not as an alternative to any type of judicial or criminal need. So when we look at discharge, the individual's documented treatment plan goals and objectives have been met. The individual no longer meets the continued stay guidelines, and the individual has appropriate support systems in the community where they can maintain a less restrictive treatment environment. So some things that would be clinically appropriate for partial is that an individual is stable enough to be medically unsupervised. So can they take their medications on their own? Or if they have medical issues, are they able to give themselves insulin? If not, do they have in-home nursing care that would be able to do that? If an individual is motivated and they show appropriate insight, that they can benefit from structure and routine. And then if an individual without partial hospitalization would be at risk for inpatient, that would be an appropriate criteria for being in programming. And that the person is able to interact, they're able to socialize, participate in group therapy, and that they require medical observation. So if they're stepping down or again, stepping up, meeting with the psychiatrist in order to see if the current medications are truly being effective. Some individuals that probably would be inappropriate for programming, those that have an uncontrolled addiction. So those are individuals that are actively using. And we just say that because we want to make sure that we have a safe and secure environment for all patients. And two, if an individual is actively in withdrawal, that could be potentially fatal. So we want to ensure that individuals that may be struggling with withdrawal are appropriately detoxed prior to coming into programming. If they have serious co-occurring health issues that would prevent them from being able, we always ask patients to, if they have any medical conditions, to please focus on their medical condition first and then be able to participate in programming. If they're actively hallucinating, organic brain disorder, lack of ongoing support, and that's so important because if we're providing individuals the tools and techniques necessary in programming, and the expectation is for them to be able to have that support to practice those skills in the community, if without support, it's really not going to be as assistive as if they had those supports. And part of programming is developing support systems if an individual does not have those. If they're unable to perform ADLs, any type of cognitive disorders, and if they are legally mandated. So some of the most common diagnoses within partial is bipolar disorder, major depression, schizophrenia, schizoaffective disorders, addictive disorders, dual diagnoses, and personality disorders. So some of the professional partners and referral sources that work with partial hospitalization is the individual themselves, family members, private practices, therapists, nurses, law enforcement. As you can see, really just the community as a whole. The referral process for most partial hospitalizations is extremely easy. It usually just takes a phone call. A lot of the services or a lot of the requirements for paperwork are minimal to none, just because those assessments are done within programming. So most part, it's just a phone call and potentially scheduling an appointment to get assessed to make sure that programming would be beneficial. And then really it's just starting up. It is really a phenomenally easy transition, again, between if you're stepping up or stepping down in levels of care. So again, it's short term, about 3 to 8 weeks. It's therapeutically intensive. It is acute treatment. It's a therapeutic milieu. It's daily active treatment. So programming can last anywhere, depending on the community center or the hospital, wherever the care is being done. It can last from like 3 hours a day to up to 6 to 8 hours a day. And it just depends if it's a partial hospitalization or intensive outpatient. That really determines the intensity of the care. There's professional staff, so you'll have APRNs, you will have psychiatrists, registered nurses, licensed mental health clinicians. So very, very, clinically savvy and experienced individuals. And it is highly structured as well. So these are those services that I spoke about just a moment ago. A lot of times when coming into a program, these are the types of things that a program will ask for you to bring along with. With partial hospitalization, that's not the case. They'll be doing the biopsychosocial, they'll be doing the psychiatric evaluation. As far as requirements, with partial hospitalization, individuals are required to meet with a psychiatrist at least once a week. And with intensive outpatient, they're required to meet with a psychiatrist once a month within programming, not at a different facility. And I think this is tremendously important because, again, the individual is able to meet with the psychiatrist, talk about any side effects they're experiencing, or if they're continuing to experience the symptoms that led to that high level of care. Whereas traditionally in the community, you're probably meeting with a psychiatrist maybe every 3 months, sometimes monthly. And now, as unfortunate as it is, it's tremendously difficult to even get an appointment with a psychiatrist. So having these really important timeframes for the med management, really, again, it increases the success of stability and continued medication management. There's evidence-based outcomes in order to track an individual's level of depression and anxiety. There are nurses that complete physical examinations. They'll do a history and physical, nursing assessments. There's individual, group, and family therapy. So traditionally, a partial hospitalization will be about 3 to 5 groups per day. sometimes even more. They may also have like a weekly individual session or family therapy, again, in order to increase the support services that the individual will have after discharge, socialization activities, case and family consultation, peer support. So one of our biggest referrals for discharge is NAMI, of course, because that peer support is what is driving partial hospitalization. So even though everyone within programming is clinical, group therapy is all about peer support. It's about normalizing things. It's about being able to share safely. And so we want to ensure that individuals that are thriving in that type of environment have the same environment to thrive in the community. And who better else than NAMI to continue that support? We also provide a slew of different modalities, which I'll get into, but really it gives us an opportunity. It's almost like we give so many different treatment modalities. It's like grabbing a handful of spaghetti, of course, after it's cooled off, because out of the pot would be way too hot, throwing it against the wall and hoping that something sticks. So whether someone really connects with CBT, or if someone really connects with yoga or meditation, or let's say they just love narrative therapy, as long as individuals are being exposed to some type of counseling therapy, then we consider that a success, because then individuals are more likely to continue that treatment modality individually in the community. There's also treatment planning, safety planning, relapse prevention, and development of behavioral plans and crisis prevention plans as well. So some of the treatment modalities that partial hospitalizations will provide is cognitive behavioral therapy, motivational interviewing, mindfulness-based cognitive therapy, solution-focused, trauma-focused. And I dab lightly on trauma-focused. If an individual is experiencing that one of their primary diagnoses is PTSD, we always connect them with an individual therapist in order to ensure that they have the ability to share their individual experience in conjunction with partial hospitalization as well. We do a lot of acceptance and commitment therapy, expressive therapy, and holistic modalities as well. So this is just the slew of different topics, diagnoses, educational psychoprocessing, psychoeducation that's providing within treatment. So depression, anxiety, mood management, boundaries, addictive behaviors, diagnosis education, family issues, sleep disturbances, grief management, and then some reality orientation for individuals that are struggling with the hallucinations, whether it be visual, auditory, so on and so forth. So some of the groups, if we get even more specific, so skills development would be considered anger management, decision-making, communication, really allowing individuals when they step back into the community to advocate for themselves, to feel empowered. So, saying, yes, potentially I was inpatient, I went to this level of care, but I got this. And now I feel more confident in my abilities to be able to manage my mood and navigate the community services that are out there more effectively. So for support, conflict resolution, developing healthy relationships. I mean, these are all things that we could all benefit from, not even just individuals that might be experiencing that intensive need for treatment, but just really day-to-day models that are very helpful. So some of these expressive therapies are writing exercises, the empty chair exercise, vision boards, art therapy, discovering passions, lots of relapse prevention. And then some examples of the CBT psychotherapy is problem solving, challenging those negative thoughts. And the DBT, which is known to effectively assist in borderline personality disorder. is mindfulness, stress tolerance, and interpersonal effectiveness. So an admission process can look like an initial assessment, completing legal documents to ensure informed consent, releases of information in order for the program to be able to communicate with other providers, whether that be active providers or providers that the individual will transition to upon discharge. Making sure that individuals feel safe in the environment, so giving a tour, introduction to group, treatment planning, and that medical and psychiatric visit. Oh, that's my favorite one. I like the bird one. So who's involved? I mentioned this briefly earlier. You're going to have the psychiatric APRN, a psychiatrist, licensed therapist, an APRN that's more so on the medical side of things, registered nurses, clinical director, program coordinator, and mental health technicians. So a lot of individuals that are able to support and provide care during treatment. So with the managing of medications, the patients can meet with a psychiatrist at least weekly, but up to 3 times a week. The medication education is provided. And again, in order for individuals not only to ensure medication compliance, but also to advocate. So for individual patients to feel like they have a voice. So if they're not feeling well, to be able to say, hey, this isn't helping me. I don't feel right. Rather than just continuing the medication because maybe it's been something they've taken for years. And then 2, making sure that the program is working in conjunction with community providers. Again, so that way, when a person transitions into the community, they don't have to retell their whole story again. They don't have to bring all this paperwork with them, that we're having active conversations to make that smooth transition for continuity of care. So what does a day in the life of a person in PHP and IOP look like? So patients participate in about 15 to 25 hours of therapy, 3 to 5 days a week. Patients typically begin the day by traveling to the facility. Some individuals, can provide their own transportation. Some individuals take public transportation. Some programs provide transportation. And then we love Staywell, because Staywell provides medication for the patients to be able to come to programming. So thank you, Brandy, for your services. It really allows individuals that potentially would not be able to participate in programming. So we really love that service is available. And then a lot of programs, whether it was, BC before COVID or during COVID, doing the telehealth. It's not entirely like doing it in person. I'm a therapist, so I love doing everything in person, because a huge part of programming is the socialization. It's learning how to communicate with people. It's learning how to develop skills that will prevent isolating. But at least it's something. So a lot of providers are also doing telehealth, which then again brings in a population that may have not been able to participate. So treatment day usually includes about 5 group sessions. Those groups will vary between the psychoprocessing and psychoeducation. There's usually about 10 to 15 minute break between each group. Some groups can be intensive. They can trigger things, and individuals just need a little bit of time to breathe. Normally there's like snacks and lunch provided. The best group will be about 8 to 10 participants. If it gets bigger than that, sometimes it's more psychoeducation than it is psychoprocessing. And then two, during COVID, you really want to ensure that you have enough space in the treatment rooms. A lot of times programs will invite community providers to come in and talk to patients to give them more options. Sometimes it's really hard for an individual to navigate when they step down from inpatient. They have an appointment within 7 days, and it's like, you have to go here on this day, then you have to go here on this day. And that can become overwhelming. So an alternative is to bring the providers into programming. Let the patients see their faces, see their logo, be able to have tangible brochures. And that really alleviates that anxiety of attending different community providers. Staff, mostly the therapist will develop therapeutic goals, but we want to make sure that they're purpose-driven and outcome-oriented. So we want to make sure that the patient is really talking about what their struggles are and what they see improvement as, because I can see improvement in mood as potentially leaving my bed 3 times a day rather than 5 times. And a patient may say, well, I already leave bed, but I cry a lot. And so improvement for them may be crying less than 5 times a week. So we really want to make sure that we're working within what the patients feel would be goals and improvements in mood. So the goals of partial hospitalization is, again, I told you that I was going to say this over and over, so I apologize, but it's the least restrictive level of care beyond, beyond outpatient. It's less intensive treatment, it's there to stabilize psychiatric condition, increasing an individual's function and level of care, preventing inpatient utilization of community services, independent medication management, to bridge the gap. Because if anyone's experienced where stairs may not be as close together as you thought, and you take that first step and you didn't realize how far down it was and you end up tumbling, that's what doing inpatient to outpatient is. It's just too big of a step. And so what partial is, it's kind of putting that safety step right in between. So as you're stepping down, it's the safest step down possible. It's really there to increase self-referral. I cannot begin to tell you how many phone calls we get from individuals that talk about, hey, it's been a couple years, I think I need a refresher, or last time I was in programming, I really had an incredible experience understanding what my red flags are, and I really want to avoid decompensating and going inpatient, so I want to come back in. So really seeing those success stories of self-advocacy, and it's there to enhance recovery and production of better outcomes. Oops. So the transition and discharge planning, it is an assessment for safety and readiness. So a lot of this is utilized through the GAD-7 and the PHQ-9, and those are assessments to gain insight to an individual's level of depression and anxiety. So being able to complete those assessments and seeing that they are in a safe range, or just what an individual's baseline is. Some individuals, they may have a higher baseline of anxiety and depression than others. There is always a multidisciplinary treatment team approach. So being able to have conversations with the psychiatrist, the therapist, making sure that a person is ready. And that the person is ready to return to school, work, or whatever their day-to-day life look like, to ensure that individuals are connected to community support groups. So a lot, there will be assurance that individuals are linked to Celebrate Recovery, AA, NA, Trauma Anonymous, NAMI, bipolar groups, that they have appointments with their PCP, their individual therapist, making sure that that is all set up. So some of the service and community collateral linkages that you'll see in programming is weekly progress notes. So if an individual is working with other providers, making sure that the program's sending out those weekly progress notes so the providers are all on the same page. Like I mentioned, that patient resource fair, so having community providers come into programming and speak to individuals so they know what services are out there. Agency, community guest speakers. So like in Pinellas County, for instance, it would be having certain community providers like Tampa Bay 211, Directions for Living, Suncoast here in the Pasco area, having NAMI again, Tampa Bay 211, AANA, having all those different individuals come in and speak to the patients and kind of allow them to transition. A lot of collaboration, and discharge planning begins at admission. So with outpatient, it's really increased monitoring, therapy, socialization, increased compliance, and intensive modalities. So inpatient is really, it's really there to ensure that the patient is able to step down. That if an individual is decompensating, they need an immediate medication change, and inpatient too is recommended if it's ensuring like the maintenance of sobriety. Some barriers and challenges with partial hospitalization is access to triggers during off hours. So sometimes that residential care is more appropriate for individuals that may be struggling with adjustment to sobriety or adjustment to their journey to well-being. Maybe they don't have a lot of supports in the community. Not having control over the environment. So sometimes individuals that are struggling with substance use, potentially they have detoxed, but they walk back into an environment where maybe their partner or family member continues to use, and that can be create a huge barrier. Poor support within the residents. Sometimes there can be long daily commutes. As stated, PHP is one of mental health's best kept secrets, which also means there's not that many around. So individuals may have to travel significant distances in order to attend. So if an individual is struggling with concentration, if they're not participating, they may not be able to gain as much as is required in order to deem quote unquote the program was successful. Cost. If individuals don't have insurance or if they have extremely high copays, that can be a barrier. If the individual has severe community stressors, and then absenteeism, that's one of the biggest ones, is the potential for individuals not to be able to follow through. So as mentioned a little bit earlier, there are a ton of success stories I can share with you, but globally, it's really about individuals feeling like they're empowered, that they're able to go back to their daily living. So we have a lot of individuals that come into partial hospitalization that are potentially on short-term disability or FMLA because they are struggling to be able to perform at work. So them returning back to work or school, individuals that have been reconnected with family because they've been able to develop better communication skills, boundaries, individuals that have left abusive relationships and have thrived in their independence. So partial is really just varied in its components of success. And so just to close out, something to share is that human nature is not an object for curiosity merely. It is the source of all our enjoyments, the sum of all our powers. It is the great artist to which poetry, eloquence, history, philosophy, and all the arts and sciences owe their existence. It is the grand instrument of feeling to which life owes all its interest. It is, in a word, that which makes us be what we are. It is our very selves. The study of it, therefore, cannot but be deeply interesting. So thank you so much for, again, joining. I know a lot of you are potentially on lunch or what have you, so I hope I didn't keep you and you're hangry now. But there's my contact information. If you ever have any additional, I'll take additional questions right now, but after, or just anything you may need from a clinician, please feel free to reach out. Thank you again.
Christine, can you tell us the difference between an IOP and a PHP?
Absolutely. So normally, when an individual steps down from inpatient, they'll transition to a partial hospitalization, which effectively the requirement for a partial hospitalization is about 20 to 25 hours of intensive treatment per week. So a lot of times that will look like about 5 to 6 hours a day for 5 days a week. So a person will be attending Monday through Friday from morning into the afternoon. An intensive outpatient, the requirements, it goes down to about 12 to 15 hours of intensive treatment a week. So usually individuals, after they've successfully completed PHP, they'll step down to an IOP level of care, which normally may be 5 days a week for like 2 hours, 2 to 3 hours, or 3 days a week for 5 hours. So it's just considered less intensive because it's a shorter time frame or a shorter amount of treatment per day. Some individuals, and there's really no, it's really individualized. So an individual who potentially is meeting with their psychiatrist and therapist just needs some additional supports. They may just step up to an IOP. They don't have to step up to that most intensive level of care. So it is really an individual plan based on the intense number of hours of treatment.
Thank you.
Yes.
Does anybody else have any questions for Christine? No? Well, thank you, Christine, for sharing all of that with us. That was a wonderful presentation.
Absolutely. Thank you for having me, Debbie.
Absolutely. We have 2 other presentations this week. One is Thursday night at 6. It's called One Woman's Story. And then the other is Saturday night at 6, and it is Bouncing Back After the Pandemic. Both can be accessed by the same link that you used to access this. And that is all I have. I hope you all have a wonderful day.